The number of people that died last year in the United States with colon cancer or due to colon cancer was about 50,000 people. That's how many soldiers were killed in Korean War, how many soldiers, about U.S. soldiers, were killed in the Vietnam War. That's the equivalent of a 737 jet airliner going down every day. To give you an idea, put 50,000 in a different perspective, because numbers, you know, we talk in millions and billions, and sometimes they don't quite ring, but 50,000 people every year. Colon cancer is one of the most preventable of all cancers, simply by getting a colonoscopy. Most colon cancers, as you know, come from polyps, which are small growths that have genetic potential to turn into cancers. Not all polyps have that potential. Basically, the younger you are when you form polyps, and the more polyps you form, somewhat increases your risk of getting colon cancer. Other things that increase the risk of getting colon cancer is picking the wrong parents. If you have a first-degree relative, first degree, of course, means sister, brother, parent, child, a first-degree relative with colon cancer, it doubles your risk of getting colon cancer. The average risk in the United States for getting colon cancer, the average person is about 6% in their lifetime, which means about 1 out of 16 people. It doubles to 12% if you do have that relative with colon cancer. If you have 2 relatives, it probably goes up, but I don't know exactly the statistics. Now, feel free to stop me anytime for questions, as you wish. Yes, ma'am.
What if your mother has cancer? You have a son. What is his chance of getting it?
That's a good question. It would depend a lot on what you had, because sometimes genes, you may not get the genes for that particular chromosome. You know, since you have a 50-50 chance of getting the genes of your mother or your father. So there is probably a small increased risk if you have a grandparent, but it's not that large. And it primarily would depend on whether you had polyps or colon cancer yourself.
So I'm saying if it's on both sides, then what is his chance?
Well, if both sides of the family, the risk goes up, definitely. Now, also colon cancer sometimes can be mildly increased chance of getting it in patients who've had other cancers, such as breast cancer, ovarian cancer, kidney cancer, cervical cancer. So that's something to keep in mind. Of course, colonoscopy is the... Who has not had a colonoscopy here? Really? Okay. Well, most of you kind of know what it's all about. And I've done 25,000 colonoscopies in my career here in Burlington, which is, if you figure the average colon's 5 feet long, that's 125,000 feet of colon I've looked through. It's usually done with sedation, so the patient generally knows very little about it, or nothing. The best sedation is called propofol, and it has to be given by a anesthesiologist or a nurse anesthetist in North Carolina. There are some states that allow the physician doing the procedure to give it with the nurse help. I'm not sure that's a good idea. As you know, propofol is the drug that killed Michael Jackson, but that's because the physician left the room. And our anesthesiologists don't leave the room. The main risk we worry about with colonoscopy is perforation. Around the country, across the board, that happens about 1 out of 1,000 colonoscopies. I'm 1 out of 5,000. I guess it's because I've done a lot. A lot of your problems occur when you're doing things for your first few years kind of learning how to do it. So experience does make a difference. Usually colon cancer has to be removed with surgery. I have removed many polyps down through the years that had a small spot of cancer in them, and there was an adequate margin of resection, so surgery was not required. Usually that's for polyps that are on the stalk, and polyps that are sessile or stuck on the bowel wall, usually we recommend surgery for all those, because it's hard to be sure of you've gotten every bit of it that way. Colon cancer is curable unless it, of course, has already spread at the time of the procedure. And areas that can spread to are lymph nodes in the abdomen, and then other areas can be liver and lung, for instance. Once a person has had colon cancer, there is increased surveillance, whereas the average population might get a colonoscopy every 10 years. They might get one every year, 2 or 3. If patients have had polyps, the kind that we like to remove, then we'll often repeat them in 3 to 5 years, depending on how many polyps they have and what size they are. Question? Yes?
What causes the polyps?
What causes the polyps? The easy answer is that it's in the genes of the lining of the colon and things that happen to the genes. The complicated answer is what exactly happens to the actual makeup of the genes. There's a process called methylation in which you attach, or the body itself will attach a carbon called methyl to a particular site on a chromosome, and this will cause things to start going haywire in essence. So it's always in the genes that form the lining of the colon. The lining of the colon regenerates itself every week or 2, and you slough off cells and new cells appear from the inner linings. And so in this way, the colon can repair itself if it gets injured or infected, because you have new cells forming all the time. Something happens to the genetic switches that tell those cells to grow and mature, and they become mutated, and rather than growing and then sloughing off, they remain and start forming growth. I have seen patients grow a cancer as early as 2 years. That's very, very rare. Usually when something grows from a polyp and into cancer, it takes a few years. But sometimes you can see much, much faster growth. Okay.
Are there different types of colon cancer?
Generally speaking, no. Adenocarcinoma is the full word for colon cancer. There are other types of tumors that can affect the colon. One is called a carcinoid tumor, and those have less malignant potential, but the vast majority of colon cancers are called adenocarcinomas and are of the same type. Adenocarcinoma is any cancer of any of the linings of the body cavities, the lungs, the esophagus, colon. Adenocarcinoma can also be in breast tissue, in lung tissue, and adenomatous tissue is the type of tissue that grows and turns into that. But that's what the normal tissue lining those body cavities is. Surgery is by far and away the most likely therapy that a person would encounter with colon cancer. Rarely, if someone was a very poor surgical candidate because of severe lung or heart disease, they might forego surgery and have chemo and radiation, perhaps as the only modality. Oftentimes, when patients have had resection, if there's any possibility that it might exist outside of the colon, they often will have an oncology consult and then possible radiation and chemotherapy. What generally determines survival from colon cancer is whether or not it is spread to the liver or the lungs. The 5-year survival rate goes down dramatically when that occurs. Rarely, if they had a single metastasis to the liver, they might try to treat that with radiotherapy, localized chemotherapy, or rarely surgical resection. Okay. Any questions?
Do you recommend laxatives? You know, if you have a problem going to the bathroom, do you recommend laxatives?
That's kind of like saying, do I recommend blood pressure for people with hypertension? Absolutely. Yeah. There used to be a myth. Well, it wasn't a myth at one time. Many, many years ago, some over-the-counter laxatives had chemicals that were damaging to the nerves of the bowel. And so that's how it grew that you shouldn't take these because they're going to make you addicted to them. Those are no longer available. So if a person has constipation, you can definitely take laxatives for it, even every day. And people say, well, does that mean I'm getting dependent on it? I said, well, it's like saying you're dependent on insulin. So,
and what do you recommend?
Oh, there's a host of different things. One common laxative is Miralax, which is what we use often to clean out people for colonoscopy, taking a small dose a day or every other day. So other things you can try are stool softeners, which come in pills and capsules, extra fiber in your diet, fiber supplements such as Metamucil, Citracel, Benefiber. And it really depends on the person. Some people have a very sluggish colon and can take all the fiber they want and they're still going to have trouble. Those are people that need to take something to help the propulsion through the colon. Your colon is basically a long muscular tube that removes water from the liquid stool and converts it into solid. And so because of many different problems that can arise, people can have trouble with things moving through too slowly or too fast, for that matter. And there's a condition called irritable bowel. I'm sure everybody's heard of this, in which some people have alternating constipation and diarrhea. Some people have predominantly diarrhea. Some people have predominantly constipation. You have no conscious control over your colon, but nevertheless there is a nervous system that runs throughout the intestines and the stomach and the esophagus that control the function. The brain has control over this, but it's your unconscious part of your system. Actually, believe it or not, there are more neurons in your GI tract than there are in your spinal cord. It's just the ones that they have are much smaller. Every millimeter of the way from your mouth to the anus is controlled by these nerves and the muscles that line the GI tract. It's basically a factory. Take in food, process the food, get rid of the waste. And every step of the way you have muscular contractions that move things through. And sometimes these muscular contractions are not real coordinated. That can cause crampy, abdominal pain, bloating, constipation, diarrhea, and especially if you've had somebody who's had previous surgery, they may have adhesions or scar tissue and have chronic abdominal discomfort. Irritable bowel I think of as a tension headache occurring inside the abdomen, and it's usually due to muscular contractions. So getting back to the original question, yes, if you have problems with constipation, you should take something. Whether that something is a prescription pill, whether it's something over the counter, whether it's milk of magnesia, Dulcolax, I think it's up to the individual person as to what they find works best for them.
I have one more. Is there any other diseases of the colon besides cancer? I know Crohn's disease, is that one of them?
There's a list about that long.
Okay.
There actually are textbooks that thick with diseases of the intestines. You had a question?
Yes. Who determines, is there any statistics on if you have colorectal cancer and they just give you chemo and radiation? Is it, that mean that your cancer has spread to your tissues and you cannot have surgery?
No, it doesn't mean you can't have surgery. It's just that I was talking about patients who have very poor health may forego surgery. Generally speaking, even if somebody has spread of colon cancer, they will remove the primary tumor and with surgery, and then treat anything that's spread with radiation or chemotherapy. Yes.
Are there any new methods of preparing for a colonoscopy that are less obnoxious?
No, they're all obnoxious. I've had 3 colonoscopies myself. They're all obnoxious. There is no easy way to do that. Yes?
What are the symptoms and how early would be the symptoms for colon cancer?
By the time you have symptoms, you're looking at serious problems. That's why we recommend colon cancer screening with colonoscopy. That's why we recommend stool hemocards if you're too young to have a screening colonoscopy. Because by the time you have symptoms, you have a growth in your colon that is causing obstruction or partial obstruction or painful contractions when the colon contracts. Therefore, you may already have colon cancer and be spread. So if you wait for symptoms, you're often waiting too late, which is why we put such an emphasis on colon cancer screening, this March being, of course, colon cancer screening month. Yes, ma'am?
You diagnose patients very often with celiac disease or gluten intolerance based on your examinations?
I have, matter of fact, 2 weeks ago, I diagnosed a patient who had unexplained iron deficiency anemia. I was doing an upper endoscopy looking for a source and found the lining looked like that was celiac disease, very subtle, and biopsied them, and that's what they had. Celiac disease is not colon cancer. It's not a malignancy. Celiac, I'm digressing, but that's okay. Celiac disease is a condition where the body becomes allergic to wheat protein called gliadin. And they form antibodies, and it will attack its own intestinal lining tissue, so that the lining of the small intestine shrivels up from this immunological attack, and that makes people have trouble absorbing certain nutrients, and it can cause them to have B12 deficiency, iron deficiency, and really severe cases, which I've not seen, it can give them severe protein calorie malnutrition. Somebody else had a hand up. Yes, sir.
What percentage of these adenoidal polyps will become cancerous if you just leave them there?
There's no way to answer that, because to answer that, you'd have to find them and leave them, and people would call that malpractice. Yes, ma'am.
I was going to ask if your instruments have improved over the 25,000 that you've done, or are they still the same?
Actually, they have. When I first was in training, they were a purely fiber optic instrument, and you had to look down the scope, the eyepiece of the scope, and I can't tell you how much neck trouble that produces. And now, rather than a fiber optic, it is a chip, electronic chip, like a television camera chip. And so the chip is in the scope, and I'm looking at a TV screen rather than trying to look through a little bitty keyhole. So that's improved. Some of the accessories have improved significantly as to the different snares and other modalities we can use to remove polyps. There's a device that's kind of like a flamethrower that I'll use. It's a catheter through the scope and to cauterize any residual tissue from removing it. So there haven't been any major leaps in many years, but it's a lot better than when I first started. Which,
you get a nice colored picture too.
Oh yeah, you get a nice picture, and It's stored in a computer if we ever need to pull it up.
Oh, I got one.
Well, I mean, if I ever needed to pull it up, let's say you come in the hospital and you have stomach problems and the doctors want to know what did that procedure look like, what did we find, and then they can pull it up easily in a computer.
Can you do that anywhere in North Carolina at another hospital?
No, no. One day we might have that kind of interconnectivity, but not right now. We have to fax a request to that hospital and have them fax the information back. Now, yes, ma'am.
If you had 2 clear colonoscopies, how long is it before you need to have another one?
It depends. What was the indication for doing it? What is the genetic background? What are your relatives? Did they find any polyps and removed them on your initial colonoscopy? And so that would all factor into the answer to the question. Generally speaking, if I scope somebody that has, for routine screening, no family history, no previous history of polyps, no other worrisome factors, they're good for 10 years. That's the current guidelines. I think that's too long of a time personally, but that is the guideline. And if you have polyps and they're removed and you only have 1 or 2 and they're not bigger than 10 millimeters, then they say 5 years. If you have more, then they would say 3 years. And if you have a polyp removed that has begun to undergo change, then that could be 1 year or even shorter. Yes, ma'am.
At what age do you recommend somebody having that first colonoscopy?
Well, the current recommendations, I don't make these recommendations, they're national guidelines, are 50 years old for Caucasians, 45 years old for black. And so if you have a relative with colon polyps or colon cancer, then you should start 10 years before that relative's polyps or colon cancer were found. There are some rare genetic disorders in which you may want to even start in your 20s. The youngest person I've seen with colon cancer was 24, and these are more of a mutation type thing. I have seen a couple of 18-year-olds with a polyp with severe dysplasia, which is like 1 step away from cancer, that I removed. Yes?
Polyps are grown due to mild genetic formation, as you explained today. What about the pockets for diverticulosis? Are they the same?
No. Completely different animals whatsoever. Diverticulosis occurs in half the people over 50. And there are pockets in the colon. Everywhere you have an artery that enters the colon wall, that is a potential weak spot. So a lifetime of coughing, straining, sneezing, pushing to move your bowels will cause pockets to form where those vessels enter. Diverticulosis tends to run in families, and generally it's not a big deal. Infrequently, people can get diverticulitis, then that's a big deal. That's infection and inflammation. It has to be treated with antibiotics and rarely surgery. But it's not in any way, shape, or form related to cancer. And having diverticulosis doesn't increase your risk of having cancer either. Yes?
Is there any foods that are good for your colon and any foods that you should avoid?
Not really. Some people, there's some studies that say, well, maybe people who are overweight on a high-fat diet might have a little increased risk. Generally speaking, there's nothing that is cut and dried. Yes, you should eat this to prevent it. No, you should not eat this to get it. Yes, sir.
If you remove a cancerous tumor, how big of a section of the colon do you actually remove?
Well, it depends on the, and I don't do that. That's a surgeon that does that. I'm a scope doctor, and surgeons are cutting doctors. It's not a cutting remark, but anyway. It depends on where it is, and the blood supply to that area often dictates how much you can remove safely and hook it back together. And if you remove one from where the colon and the small intestine begin, then you might remove a larger section because of the blood supply than if you're removing it from the other side of the colon. Okay.
Does the colon ever regenerate that part you took out and fill it in again?
Not to my knowledge. Not to my knowledge. I often wonder, sometimes when I scope people, and scope them years later, it seems like their colon has gotten longer. And it may just be a matter of...
You're just bored. You just got bored.
No, I never get bored. That's the funny thing, that everybody's different. Every little inch of the way is different. And you pay very close attention to every little turn and twist, because you could easily be inside of a diverticulum and be ready to perforate something. So you have to, there's nothing about boredom to it. And I have done as many as 12, 14 a day. Usually an average day is about 6 to 10. Has anybody ever heard of stool transplant?
Yes.
Raise your hand if you have. Okay. Has anybody ever heard of C. diff colitis, Clostridium difficile colitis? Yeah. As you know, C. diff colitis is due to taking antibiotics. The antibiotics wipe out a lot of good bacteria, and now this C. diff, Clostridium difficile organism can grow and prosper. And we can kill it with antibiotics, but it often can come back about 20 to 30% of the time, because when the bacteria, this is not anything to do with cancer, because the bacteria, when they die, they release spores, and these spores can grow into new bacteria. And so you can get a reinfection all over again. And I have seen patients go through 3 and 4 rounds of antibiotics trying to get rid of this infection. And we just started doing stool transplants from healthy donors, which replaces the stool in their colon and crowds out the C. diff. And we've done 10 patients so far, and all 10 have had an immediate cure of this. Now I'll give you some interesting statistics. I hope everybody's eating. But there are more bacteria in your colon than there are cells in your body. We're talking on the order of 20 billion, in that range somewhere. Half of the poop that you pass is pure bacteria by weight. That's a staggering thought. There are some people who are suggesting that some autoimmune diseases may be related to the bacteria in your GI tract and the metabolic products that they produce. There are over 2,000 different species of different bacteria in your colon. They're doing some fancy genetic mapping of the flora of the human body, the bacteria that exist everywhere in the body, in the mouth, in the eyes, on your skin, and in your GI tract. And they're starting to map this out and discover what particular types exist. And they're finding that certain classifications of bacteria are increased or decreased in certain medical conditions. This is kind of a state-of-the-art thing. It's going to be seeing more about this over the next 10 years. Yes, ma'am.
Since you're on this poop, whatever, my granddaughter said that cranberry juice make her fart.
Uh-huh.
Okay, when you releasing, you saying most of the bacteria, is that damaging your colon when you pass gas? I say pass gas.
No, no.
Damage your colon?
Actually, Ben Franklin wrote a small book called Fart Proudly. True story. Gas is a natural process of digestion. So having the more gas, the healthier diet, such as fruits, vegetables, cereals, whole grains, the more gas you generally tend to produce. Yes?
What do you think about the foods like yogurt and some tablets that have the probiotics added to them?
There's been several studies, and a few of them have suggested a benefit. There's nothing that's been very strongly shown positive, but the other idea is that they don't hurt anybody. So oftentimes we will tell people taking antibiotics to either eat yogurt or to take a probiotic pill. And these are good bacteria. And I would say probably 25% of my patients with irritable bowel seem to get better with eating yogurt. I'm not paid by Dannon or anybody that say that.
Do cancer, colorectal patients, do they have to be careful about certain foods that they're eating, like breast cancer patients?
No.
With estrogen-fed soy products, that sort of thing?
Not to my knowledge. It's not a hormonal-driven thing. So,
most yogurt has soy in it. Just basically everything has soy in it, it seems.
you must read labels. Okay. Any other questions? Thank you for having me. Take care.